We will get started. Good morning and welcome to our the second part of our two-part series on the important topic of understanding frontotemporal degeneration, FTD, as we will be referring to it throughout the program here today. We're very happy that you're here. My name is Amy Abrams. I am the Director of Education here at Alzheimer's San Diego. I run our community and professional education programs, joined by two terrific guest presenters here today. First is Adriana McCollum, who is our Director of Social Programs and Volunteers here at Alzheimer's San Diego. Welcome. Adriana oversees our volunteer program and was one of the great inspirations for this, our developing this important topic. So very pleased to have her with us. And of course, we are both delighted to be joined by Sharon Hall. Hi, Sharon. Let me read you briefly a little bit about Sharon because her bio is extensive and I don't know it right off the top of my head, so I've got to read it. But Sharon is an FTD advocate, a certified caregiving consultant, and an Eden associate. She's been trained by the Association of Frontotemporal Degeneration, the AFTD, who we will reference here later today as well. And she serves on numerous dementia advisory boards and educates the public and professionals about FTD and its many complications. Ms. Hall has spoken at numerous conferences and webinars and has had numerous articles published on the subject. She has a podcast about FTD and facilitates a bi-weekly caregiver support group via Zoom. Importantly, FTD is also a lived experience for Ms. Hall, who's also the care partner to her husband, who's been diagnosed with the behavioral variant of FTD and lives with her at their home. So you are all going to learn a great deal from Sharon and Adriana here today. Very pleased that you all could make it. Welcome. Welcome. So let me just tell you briefly about who we are at Alzheimer's San Diego. We'll review some resources and additional support that is available at the end of the program. But Alzheimer's San Diego is an independent and local nonprofit organization that serves people here in San Diego County and anywhere who are affected by Alzheimer's disease and other types of dementia. We support people whether there's a diagnosis or not, any form of dementia. And as I often say, it doesn't matter if the person is here in San Diego, if you've got a connection to us in San Diego County, we are here to serve you. So I know there are some folks here in the webinar today or watching the recording later who are not here in San Diego County. We're going to be talking about some local resources at the end of the program, but we'll also make sure that you know how to find resources in your area. So our mission at Alzheimer's San Diego is to help people impacted by dementia, to fight stigma and to support research. And one of our funders, and a terrific source of support for us here at Alzheimer's San Diego, is the San Diego Imperial Geriatric Education Center, which runs something called the Geriatric Workforce Enhancement Programs. We're very pleased, grateful to that support and pleased to be a part of our local GWEP collaborative. So let me just go through some kind of housekeeping stuff. There is a Q&A function box in your Zoom controls. Please use that to submit questions, and you don't have to hold them. We're gonna pause and break for some questions at the end of the program, but please go ahead and type in those questions as they come up for you, and we'll be sort of keeping track of those as we go along, and we'll answer as many as we can when we get to the end of the program. If you'd like to use the chat to introduce yourself or to share resources, you are also welcome to do that as well. Just go ahead and make sure you're sending your chat to everyone so that everyone can see it. So recordings of both part one of this program, which we completed last week, and today's webinar will be available in our webinar library on our YouTube channel, excuse me, but they're also archived to the professional education page of the Alzheimer's San Diego website. So if you didn't participate in part one, that's fine. These are standalone programs and you'll understand everything we're talking about here today just fine. But if you do want to go back and watch it or review it, both programs will be available. For this program, we are assuming some general dementia and Alzheimer's disease specific knowledge, because we talk in these programs about how FTD is different from Alzheimer's disease. So if you need more information about Alzheimer's disease or dementia more broadly, please let us know. Reach out to us at Alzheimer's San Diego. Visit our website. Lots of great information there at alzsd.org. And again, we are going to be providing resources at the end of this program for more education. So here on the screen, you see the objectives for this program. I'm going to start by talking about giving a very brief kind of review and introduction to FTD, talking about strategies for addressing behavioral symptoms and the key safety considerations for people living with frontotemporal dementias and their care partners. Sharon will be talking about two very important issues: legal planning, financial management, three issues, and palliative care as a critical source of support for people affected by FTD. And then Adriana will be talking about best practices and training methods in supporting caregivers for people living with FTD. So that's our plan for the morning here. Let me just start with a very brief recap for familiarity with the terminology of frontotemporal degeneration or frontotemporal dementia. It is both terms are used. FTD. So FTD is not one specific thing. It's a range of disorders, and you see on the screen there the various subtypes of FTD that are out there. There are also subtypes of some of those subtypes. So there are many different types of frontotemporal degeneration. The behavioral variant, which is, you see the second in the list there, annotated with the BV, FTD, the behavioral variant, is the most common type of dementia. So it's this range of disorders that are caused by neurodegeneration, specifically within the frontal and temporal lobes of the brain. Like Alzheimer's disease, these conditions are progressive. There are no known treatments or cures for FTD. They're different from Alzheimer's disease and other forms of dementia in a variety of ways. I think two key things are that they tend to affect younger people than Alzheimer's disease on the whole. That is not always the case, but just statistically speaking, they affect younger people. And in the early stages, there is usually just one primary symptom. It is not always, in fact, it is not usually a memory symptom. So that's something that makes FTD much trickier to detect and to diagnose because people are younger and memory symptoms are not always prevalent. It's often more about behavior and language, as well as some movement related symptoms. So again, in very brief recap from part one, the impact of FTD on families and care partners, as in all types of dementia, the impacts are profound. We've got usually younger, healthier, physically stronger people who are now impacted by this neurodegenerative disease. They are experiencing functional losses and changes at a much younger age, usually, and often while still employed, maybe while still raising families, which causes a variety of complexities and difficulties in their lives. And then you layer on all of these various movement, language, and behavioral symptoms. It is a challenging endeavor, to be sure. So let me start in addressing the behaviors related to frontotemporal dementias. Medications, of course, are just sort of one line of defense, I guess, of treatment, but they are an important one. It is important that we all, as professionals who are supporting people living with FTD and their care partners, that we recognize that people with FTD are frequently first misdiagnosed, as we talked about in part one, but once diagnosed, then sort of treated incorrectly. The challenges of treating FTD symptoms are many. People are often incorrectly medicated, or as we refer to it, chemically restrained, which is technical language for basically being snowed by incorrectly used, prescribed, or dosed medications. one of the great challenges we have here is that there aren't drugs that have been FDA approved specifically for FTD. There are some Alzheimer's disease drugs, right? Most of us are familiar with the Aricepts, the Namendas, the Exelons of the world. These drugs are not recommended for people living with frontotemporal dementia. They're not effective in people with FTD. They're not effective at managing symptoms, and in fact, may be harmful when used in some types of dementia. But because there is this lack of understanding, both on the part of medical professionals, but all of us in support organizations as well, often, when Aricept, for example, is prescribed to a person with a new diagnosis of FTD, we may not know to challenge that or to question that. So the drugs that are FDA developed and prescribed, approved by the FDA for Alzheimer's disease aren't recommended, but antidepressants frequently are used, as well as antipsychotics in managing the symptoms of FTD. For better or for worse, right? They're not always effective. They're not always the right choices. This is definitely an art, and physicians, psychiatrists, neurologists often need to do a lot of tinkering to find the right medication, the right dosages, the right time of day to administer these things. For all of these reasons, palliative care is a critically important sort of piece of the puzzle when it comes to managing the symptoms of a person who's living with FTD. Sharon is going to talk more about palliative care a bit later here in the program, but I just want to introduce that now as an important source of support for people who are struggling with all of these medication-related questions related to FTD symptoms. We tend to not think of palliative care for people who are still in the early stages of a progressive form of dementia, but we do need to make an exception in the case of FTD. So medications are a piece of the puzzle, but of course, behavioral strategies are what we at Alzheimer's San Diego tend to focus on more heavily in teaching and supporting people living with a diagnosis and their care partners, both family and professional caregivers alike. As in any other type of dementia, we should keep in mind that people living with FTD can't control these symptoms. I know that kind of should just go without saying, but it is good for us to kind of keep that in the front of our own consciousness. This is not something that person has any control over. And when you're visually looking or physically in the presence of somebody who looks so healthy, who looks so much like their old self, it can be really hard not to think that this person is just purposefully, pushing your buttons, trying to manipulate you in some way. I know very well how that feels. The person with FTD, though, cannot control what's happening with them. It's really on us, the professionals that support these folks and the family members and other care partners who care about them to make the adjustments. So when I talk about behavioral strategies, making adjustments, compensating, I'm usually talking about things we need to do internally, not something we need to expect the person who's living with dementia to do. Patience, of course, is important in all types of dementia care. In Alzheimer's disease, we tend to see symptoms related to memory appear very early on. And so there's just a lot of repetition and dealing with somebody who's experiencing rapid forgetting, and in particular, short-term memory loss. And I mean in no way to minimize how frustrating and impactful those memory changes are when I say it's different in FTD, because often the person isn't experiencing any memory loss. So you do need patience and tolerance, but it's a whole different level. It's a whole different type of patience that is required. And it requires an extra focus on safety. In FTD in particular, safety awareness, insight into one's own behavior is often a significant challenge and barrier. Keeping the person living with dementia safe, keeping the care partner safe is of critical importance in in managing the behaviors of FTD. So we need to encourage, especially family care partners, but anybody who's involved, to encourage people to depersonalize what they are seeing, what they are hearing the person say. Often there is a real disinhibition that we see in FTD in particular. And again, it often happens very early on, before people are even aware that there is a form of dementia at work. So learning to recognize inappropriate, offensive, hurtful comments, gestures, physical gestures, learning to depersonalize those is really important. This takes, again, patience, but also just a lot of disease knowledge and education. Understanding the individual person's triggers, super important in FTD. There does tend to be a lot of compulsive behavior in these disorders, as you heard a bit about in part 1, and you'll hear more about later. So figuring out for that individual person, what are those triggers that trigger the behavior, that trigger the compulsive eating, for example, or the repetitive compulsive activity, figuring out what those triggers are for that person, understanding them and managing them as effectively as possible, de-escalating situations, learning to, as in other types of dementia, learning to let go of accuracy, focusing on the facts of what a person is saying, or a very literal interpretation of what a person is doing, and instead looking for what's behind it, focusing on the meaning of that behavior to that person in that moment, in that particular context, is really, really important. So we call this validating the person, just sort of agreeing, letting go of trying to correct people, trying to reorient people, or trying to get someone to see what you've just said or what you've just done is problematic. Right? We have to sort of just be in the moment with that person, and again, recognize their inability to make those adjustments on their own. One very effective way that we can do this is by simply apologizing. You're right? Sort of hands up, literally and figuratively. You're right. Right. I'm sorry. I'm sorry. I didn't see it that way. Right. Apologizing and agreeing with people in whatever way kind of makes sense. Is an important skill for people to develop. And we have to sort of swallow our pride a lot in doing this. We have to, I often say, we eat a lot of crow in that we don't need to eat when it comes to supporting people who are living with dementia, who are experiencing confusion, disorientation, or disinhibited social behaviors. So just learning to kind of let those things go. I think maybe even more important in FTD symptoms than in Alzheimer's disease symptoms is really learning to respect personal space, right? Knowing that if you're too close, that can really be a trigger for them reaching out, physical touch, making comments, making gestures, and learning when you need to just sort of walk away, to give the person their space, to keep them safe, and to keep yourself safe as well. Of course, we don't want to walk away and leave a person alone who is not safe to be left alone. We'll talk about safety here in a moment. All of this is a lot for any one person to be thinking about, to be managing, to be making these constant little adjustments day in and day out. This is exhausting, as any FTD care partner will tell you. So we really have to support not only the person living with the symptoms and keeping them safe, managing their triggers, making those environmental adaptations as we can. We absolutely have to meet the time and space and rest needs of the FTD care partner. They are frustrated, they are fatigued, they're for all of those reasons I described a few slides ago. They are in it pretty deep, pretty early on in this disease process. So managing the support needs of the care partner is just as important as any of the others. For all of the reasons described before, safety is of utmost importance in developing a care plan and supporting a person with FTD, right? Thinking about household injury risks, injury risks related to wandering. Wandering is important, an important risk factor to be considering in any type of dementia, of course, but especially when we've got very young, very mobile people who are very likely to still have been driving, to be physically active. Wandering takes on a whole new level of complexity and severity. We'll talk about some of the resources for responding to wandering at the end of the program, but I do really want to encourage you, if you're supporting a person who's affected by FTD, don't wait to be thinking about these safety issues. Talk about these issues early. And wandering and driving, I think probably two really, really big issues that are hard to talk about with people who are still very young, still very functional, and still living very active lives. But it is important that we sort of acknowledge the progressive nature of these conditions and start these conversations as early as we possibly can. I talked about caregiver safety. I think for all of the reasons described before, the behavioral symptoms, the physical strength of a person who may be younger and living with FTD, the fact that they may be driving, the fact that they may have access to firearms, for example. There are many reasons that we need to emphasize the safety net and the physical safety of care partners as well. And Sharon's going to be talking more here in the next section about these next two issues, but financial safety and in particular preventing people with FTD from various types of abuse is very important. So Sharon, I'm going to go ahead and turn things over to you now. She's going to talk more about these legal and financial planning issues and the need for early palliative care intervention in people with FTD. Welcome.
Thank you. I just want to say before I begin here that these women know FTD, and I encourage you, if you live in the San Diego area, to reach out to Alzheimer's San Diego if you are in the FTD community or work with people in the FTD community. Adriana and Amy are exceptionally knowledgeable about FTD, and it is the exception. Next slide, please. Legal planning needs. It's really important with FTD as early as possible to get your person to participate in their decision making. And what does that mean? It means that encourage them to, if they have enough cognition, because sometimes when we're diagnosed, it's pretty into it, because we all know that this is kind of it creeps up on you kind of thing because of the behaviors. They just get progressively worse sometimes. So, but you need to address as early as possible. And I always tell everybody that they should always have a conversation about what their end of life looks like. So I don't care if you have FTD, Alzheimer's, or nothing at all. If you are over the age of 21 or even before, you need to let your family know what you want. And does that mean you want a feeding tube? Do you want everything possible to keep you alive no matter what? Or just make me comfortable, because this is a terminal disease. I know it's going to be fatal. I know I'm going to lose myself. This I don't want. I don't want a feeding tube. I don't want to be resuscitated. I don't want to be intubated. So those are the things that are really important to discuss with people, even before diagnosis, but certainly as early as possible when you have a diagnosis. You need those powers of attorney. You need the healthcare power of attorney, and you need the durable power of attorney for decisions that are financial. So you need to have those powers of attorney, and they need to be able to know that it's okay for them to give you that power. And in our particular case, I had not only myself as Rod's power of attorney, but I also made my son and my daughter-in-law powers of attorney, and I made it available immediately. So let's say Rod and I are in a car and we have an accident and we are both disabled. I need to have somebody make everyone's decisions. So I put additional people on our powers of attorney, both financial and medical. And it came in very handy when I broke my leg and my daughter-in-law had to go with me, and she just handed over the power of attorney for healthcare, and they told her everything she wanted to know. So it's extremely important to think about that as well. Don't just, a person with FTD cannot have your power of attorney. So think of that as well. They need to have, you need to have someone other than the person with FTD be your power of attorney, but it is needed in case something happens to you. So these are important decisions you need to think about, and people need to think about, and they need to be encouraged to have these things done. Your advanced healthcare directive, I just talked about that, about do you want intubation? Do you want to be resuscitated? Do you want to be on a feeding tube? Those are the kinds of things that you really need to make clear. The best way to make that clear is to have a POLST, or some states call it a MOLST. It's a physician who signs orders for the life-sustaining treatment. So a physician signs the order that you're not to have resuscitation, you're not to have a feeding tube, you're not to be intubated. Those are the kinds of things that get onto this POLST and are a doctor's order. So they go with that person whenever there is any kind of emergency. So I leave mine on the refrigerator. I also have here in our state, we're doing Plan in a Can, which puts that information, all this important information, into a tennis ball can that we could just grab and go, and it has everything we need in it. But a POLST is important because it's the only legal way to make your things that you want absolutely in concrete. No one can go against a POLST. So the EMTs come, you have a POLST, that means I don't care what, they don't resuscitate. It says here that the doctor says do not resuscitate. So that's a very important step that a lot of people don't understand. Sometimes a healthcare directive, they can overrule you. So make sure you have as much legal documentation as possible if that person does not want certain things to occur when some emergency happens. Conservatorship, difficult, but oftentimes extremely important in FTD. And the reason for that is conservatorship, this is not guardianship. Guardianship is your health. Conservatorship is your money. So conservatorship means that you have to set up a separate account with you and that person's name, and every penny that is spent on that conservatorship has to be for the person that you have conservatorship over. So you need to keep very detailed information about that. It's important for you if this person has spent a great deal of money prior to being diagnosed, perhaps has sent money overseas and scams and things like that, to have that conservatorship. It is sometimes with FTD not easy. The courts do not understand FTD. The person looks young, the person looks healthy, and oftentimes, most of the time, they have a anosognosia, which means they don't acknowledge that anything is wrong with them. So they show up in court for a conservatorship hearing and they look just perfectly normal. And the judge goes, well, there's nothing wrong with them. This person must be wanting to scam them. So it's very difficult. And those of you that are professionals on this call, please let your people know that have FTD, if they are going for conservatorship, that you will in fact testify to what FTD is. It's important, and even then sometimes it doesn't hold water with the court. So it's important to educate court. You have to locate an attorney with elder law experience, and there's a National Association for Elder Law Attorneys, NAELA.org, which gives you the opportunity to look in your area for someone who is certified in elder law. That's important. It can't just be your neighbor 2 doors down who does divorces. Elder law attorneys have special training in order to be able to protect the assets of a surviving spouse if you need Medicaid, and they are very good at setting up trusts that are enabled if the person needs care. So an elder law attorney is very important when you're doing your legal planning. Next slide, please. Financial safety, early intervention as soon as possible. It's sometimes difficult. We know they have anosognosia. We know they have no awareness of their disease. Nothing is wrong with them. It's always somebody else. But if you don't get a handle on that money soon, you can lose everything. And we have people that have done that. So this is one of those red line issues. Also, driving is a red line issue, but we'll get to that. Driving is a red line issue, just like financial. It's something where you cannot back down. You must get control of those accounts. You have to restrict their access, hide the emails, change their email login, whatever it takes to get them away from getting to financial accounts is paramount. So always, if you're dealing with somebody with FTD, and if you're a healthcare professional, please stress this to people who you see with FTD, that they must get a hold of the financial dealings of that family. They're extremely susceptible to scams and financial abuse. It's very common for them to send money to the Nigerian king to make $1 million, or for somebody to get a hold of them online and say that, oh, I'm just, I've lost my home and I'm out of a job, and could you just send me $1,000? We've been talking for a while. Those are the kinds of things that these people get involved in. So you have to be very, very careful with online, with them being accessible to the internet and being accessible to these scams. So it's very important to keep people away from that. There's a very heavy financial burden due to FTD because of its young onset. The Association of Frontotemporal Degeneration did a study, which was published in Neurology, saying that the cost of FTD is $120,000 a year versus Alzheimer's at $60,000 a year for a family. Part of that is due to the fact that they lose their jobs early, and so their Social Security disability is small. You have a waiting time for disability, and they wait 2 years for Medicare. So it's extremely important to know that this is a heavy financial burden. FMLA, you have Family Medical Leave Act, you certainly can enact that. If you are a care partner and you need to stay home, you can certainly enact that at your own place of work. It's not for all time, but you have that ability. And for Social Security disability, FTD is considered a compassionate allowance. So that means that it's moved to the top of the deck, but it does not do away with your waiting period or the fact that you have to wait 2 years for Medicare. That is still the same. There are a couple of bills on the floor, and I'll have Amy send out those in the federal government. There's one in the House and one in the Senate to drop the wait for both getting your Social Security disability and for getting on Medicare initially and not waiting 2 years. So we'll get that information to you. But the problem that you have with these financial situations are you're dealing with the pride of the person who has FTD, the fact that they don't have acknowledgement of their disease. There's some shame and embarrassment and guilt involved, even on their end. They probably know they shouldn't have sent that $1,000 to the Nigerian king, but gee, it sounded so real. I really thought he was going to give it to me. Also, things like Publishers Clearinghouse. People can spend thousands of dollars because they think if they buy all the magazines, they're definitely going to come to your house. So those are the kinds of things that may not be the things that you deal with Alzheimer's. So we're talking about the differences here. These people are very aware. They sound very good. They don't sound like they're older. They sound young and they have all their facilities about them, but they don't. And you sometimes can have guilt that you are taking away all of these things that are so important to our very being. I can't take care of my financial things myself. I can't drive. I can't. So there's some guilt when you have to say no. So on our chat, we have someone that always says to change a no into a yes. So that takes a little bit of skill too, just like Amy talked about some of the things previous, but don't have guilt when you take over these things because it's protecting you. It's protecting you. So make sure that you protect everyone in the family by getting a hold of those financial dealings. Next slide. Palliative care, ding, ding. I know most of you go, palliative care, well, that's when somebody's going to be dying soon. No, it isn't. Palliative care is available to anyone from a diagnosis of a life-limiting illness. And if a fatal disease isn't life-limiting, that has no cures and no treatments, I don't know what is. So always suggest palliative care at the beginning. When you get a diagnosis, you should even be asking that neurologist for an immediate palliative care referral. You do need to be referred by a physician for palliative care, but there is a website, getpalliativecare.org, where you can find palliative care in your area. There are also some very specialized palliative care people called neuropalliative. And oftentimes that is a very good fit for someone that has a neurological disease such as FTD. It's going to improve the quality of life. They are all about quality of life. And they reduce the suffering related to those medical and psychiatric symptoms. So they're going to be the sort of a care manager for you to deal with your other physicians and make sure that what's happening, that you're not over medicated, the person is not over medicated, so they can have a quality of life, so that they continue to do the things that they find important to them. And it gives the caregiver support as well. So that caregiver can get some training and acknowledgement and be able to talk to information about what's going on with FTD and the spiritual well-being. They also will have a spiritual person in their group. So it's a doctor, a nurse, a social worker, and a chaplain. So you're going to have those people available to you, and it helps you plan for the future when someone is involved from the beginning. The other thing that it happens is they are involved from the beginning. So they see all that progression that is not like Alzheimer's, and the qualifications for hospice are Alzheimer's based. So if you have palliative care with FTD early on, they will see this person changing and can even suggest to you before you might even think about going on hospice care. So palliative care is extremely important at diagnosis, and it is person and family centered. They can meet with your family if they don't understand the diagnosis, if they don't understand what's happening, if people are disagreeing about placement or anything like that. A palliative team can sit down, make a meeting with that family, go through what's happening, why these decisions are important. You may have a grown son or daughter who says, Dad can still drive. He's just fine. I don't see anything wrong with him. Well, that palliative care team can set up a meeting and say, here's what can happen with Dad. If he has language issues, what if he can't tell the policeman what's going on? If he has behavior issues, what if he has road rage and the policeman wants to shoot him? So you have that support there of someone who can meet with your family, give your family the information they need, and it isn't you, because sometimes they don't believe you because they look at this person and they go, oh, they look fine to me, they talk fine to me, I had a perfectly good conversation with them, there's nothing wrong. Well, families can be difficult to deal with, and a palliative team can help you get through that. So that's why it's extremely important for them to be on board early. Next slide, Amy. Palliative care myth, palliative care reality. These slides are going to be sent to you. This is important for you to know. There's a difference between palliative and hospice. And I'm not going to read all of these to you because you're perfectly capable of reading and you will get these slides. But this is an important thing for you to remember as a professional. Even professionals get it confused. Oh, you're not ready for palliative care. You're ready for palliative care at the beginning, And let's not forget, when you have palliative care and you have cancer, you could still receive chemotherapy. That's a curative type of treatment. So palliative care is not about, I'm dying tomorrow. So read over these when you get these slides sent to you for being in this session, because this is important. Print it out and remember, palliative is not hospice. Very, very important. Next, Amy. This is how you get it. Medicare and Medicaid covers it. Most private insurance covers it. You have to be self-advocating. Most doctors will say you're not ready for it. The hospice criteria, as I said, is based towards Alzheimer's. So it's not widely recognized, although it's been around quite some time. And it's available in any setting. If your person goes to the hospital, ask for a palliative consult. That palliative care team, sometimes they call it support service, but because palliative, they don't understand and it gets confused with hospice, but someone there will be that team that can help you with this. So make sure that with this palliative care, you absolutely educate yourself, even more than what I'm telling you here, about the very much need for palliative care, even for Alzheimer's from diagnosis. As there are some families with Alzheimer's that absolutely argue about placement. So a palliative team, that's what they're there for. They're very, very astute in these types of things. So they're accessible anywhere. If you look at getpalliativecare.org, you can see if it's a hospital, a facility, or home palliative. Most hospices also do palliative care, although some of them will even say to you, oh, you're not ready for palliative care, but you are. So that's why you have to be a self-advocate. So next, Amy, I think we're at the end here, and we're going to turn it over now to Adriana, and she's going to talk about best practices and training and supporting caregivers. And then we'll have questions at the end. Take it away, Adriana.
Thank you, Sharon. Good morning, everybody. Go ahead and on to the next one, Amy. Well, I'm delighted to tell you about our Alz Companions program. This is one that I was actually hired to create back in 2014. This is a program where we provide a trained volunteer as a companion to individuals living with dementia, any kind of dementia. So we do serve people with FTD. This is a kind of a dual goal, dual purpose program where we really want to provide that companionship, the socialization, a friend to the person living with dementia, but also as important to provide a break for the care partner. So the volunteers are give about a 4-hour weekly visit, and they do anything from reminiscing, playing games, taking walks. The volunteers really there to listen to the care partner and the person with dementia in terms of what would be meaningful ways to engage with the person, ways to try to get them to do activities that may be new to them, just to kind of provide a little brain stimulation, but also respect the limits of what they're able to do. The volunteers are matched with the family, with the care partner and the client living with dementia. This is to build that relationship, build that connection, the familiarity. And I think that's one of the reasons why this program is so valued by many care partners. Not only they get a break, but they get the comfort that they know that the volunteer is there to spend quality time with their person, who the volunteer ends up developing, caring for the person and wanting the best for that person. So it's more than just kind of a random caregiver coming in to provide a break. The volunteers are trained and receive guidance from Alzheimer's San Diego to navigate issues, and I'll talk about the training in a moment. We have worked with hundreds of families, so this means care partners and clients since the beginning of 2014. we've had the opportunity to learn a lot. And I think I mentioned in the last program, we had a volunteer on a visit let his person with FTD eat 9 ice cream bars on the visit. So we missed that one a little bit, but we definitely learned from it. And another individual with FTD demanding that their volunteer leave, but the care partner was gone out of the house. So we can't have the volunteer just leaving the client alone. So the volunteer kind of hid in another room just to, decrease that agitation and kind of listen in and check in on the person without the client knowing. So we're always available by phone to guide the volunteer, help them navigate situations like this. A lot of it is using redirection and all of those things that Amy mentioned in terms of, apologizing, kind of diffusing the situation. So we have learned a lot of best practices, but I think the most important thing we do is that we listen to the care partners. And they know their person the best. They know what the triggers are. They know what to avoid, what to use as things to redirect their focus on. If there's a certain activity that the person with FTD enjoys. So we really, it's a case by case basis. It's really individual, like all people with any kind of dementia. But we've definitely learned a lot over the years, and we use all that information to keep using best practices in running the program. Next one, please. So in terms of the training and support needs, the training is a minimum average about 8 hours. We will interview and screen the volunteers. And the first thing is to see what their knowledge gap or what the knowledge base is. Many of our volunteers come to us because they have personal experience. They have a grandparent or a parent, or their boyfriend's mother has dementia. So a lot of them are drawn for personal reasons to this volunteer role, which kind of builds that investment in the very beginning. The training program includes video presentations, a lot of reading. There's quizzes, heavy dose of TIPA snow, and positive approach to care, training workbook, as well as continuing education. We are always available by phone and email, and to provide any kind of guidance and advice in terms of how to handle a situation. The volunteers are required to provide visit reports following every visit, and we read every single one of those, and we'll always provide some guidance and information if maybe the volunteer could have handled it a different way, maybe a little more sensitively about a situation. So we're always there to really provide that support to the volunteers. Safety is a huge consideration, of course, for both the person living with dementia with FTD and the care partner and volunteer. Part of our program includes a home assessment, which is done in the very first steps of the enrollment, where our program social worker will go to the home. And in addition to just asking questions to determine eligibility and appropriateness for the program, such as, does the person have a lot of aggression or violence that may be a danger to the volunteer. The program social worker is also asking questions and looking around about safety issues. So the staff person from Alzheimer's San Diego is there in the home to get an eye on things, to provide recommendations, to initiate any kind of home improvements, in terms of contacting agencies and organizations that can help with that, to keep it a safe environment for everyone in the home. And in terms of the supports, one thing that's important for care partners to know in terms of the training is that we let the volunteers know very well that the people living with dementia with FTD may say inappropriate things, they may swear, they may have disinhibition. The volunteers are trained for this. And I think, a lot of the care partners are nervous. They are anxious about having the volunteer there because they're afraid of what their person may do or may say. But the volunteers know to expect this. They know how to handle it. And we're always available by phone during the visit if there's a situation that comes up that needs some, extra navigation. We always reinforce that the volunteer joins their reality to avoid any agitation or fear, paranoia. There's a lot of reassuring. And my team, there's 3 of us, we will provide support in the moment, and we're there for not just the volunteers, but also the care partners, where the volunteers let us know there's an issue, the care partner can communicate that through the volunteer, or the volunteer may notice something and let us know, when we're always there ready to give the care partner a call to provide support. Next one, please. Of other respite programs and care services, at Alzheimer's San Diego, we do have lists for places if you're looking for any kind of, memory care, skilled nursing, boarding care, even hospice options. We have in terms of vetting providers, we have a list of interview questions that we can we provide you. These would be questions about maybe security of the facility. What do they do to prevent wandering? What is the dementia training they have for their staff? Are there different kinds of wayfinding techniques available in the residential communities, such as memory boxes or themed halls? Things that you may not think about that would be ways to really discern if it's a good fit for you. In terms of finding a good match, that was for residential care. For in-home care, the things you want to do is, find out, one, are they serving your area? Right now, there is a shortage of in-home caregivers. So it's a little bit more difficult than usual, but you should still ask discerning questions like, do you have no-show policy? So if the caregiver just ends up not coming, do they have a notification system, ways that you can ensure the safety of the person living with dementia? The options and challenges for residential care. As I mentioned, we have a list available, and we can make recommendations based on location for finding a good residential care option. We also have good experience to base some of the challenges that we've seen in terms of there's cost, of course, is number one. And as we've mentioned before, with frontotemporal degeneration, a lot of the individuals are young. And so the aggression or agitation could be an issue in terms of being managed by a residential care community. Also, someone who's younger may not fit in with all the older residents who live there. So that's another issue that you may encounter. Additional support for care partners and for others who are, supporting individuals with FTD. Definitely should seek out education. The more you know, the better off you are in terms of what you're dealing with. It's so complex. There's just so many different facets to be aware of. Support groups is a huge thing that we recommend in terms of combating the loneliness, the trauma, and the challenges, and to learn from others, because education can be hard to get in terms of really knowing what you're dealing with. So having others to support you and to for you to know that you're not alone is really important. And let's see. In terms of there's the Association for Frontotemporal Degeneration helpline. This is available during regular business hours. The phone number is listed there. You can even click on the phone number on their website, and it will launch a video app for calls, or you can contact them through their email address. There are also awareness cards. So these are little cards that indicate that the person you're with has frontotemporal degeneration or a form of dementia, that you can hand quietly to someone at a restaurant or a bank to indicate the person that you're there with has some kind of memory or cognitive impairment. The ones that are on the AFTD website are also in Spanish. Alzheimer's San Diego, we have a lot of resources. We have over 30 support groups, including one for FTD. We have our education classes. These are live and recorded. Topics like managing resistance, communication, safety. There are skills clinics for care partners for bathing and hygiene, meals and eating, many more. We also have classes in Spanish now. Our clinical services team is available by phone or for video meetings now. Soon, hopefully we'll be doing in-person meetings, but they're always available by phone to help navigate a situation or to provide information referrals. And then we also have our social activities where it's a wonderful place for people to come together. No one, judges any behaviors. We have fun activities planned for, a little bit of brain stimulation. And these are several times a month where care partners can come and bring their person and just sit back and relax and enjoy connecting with others. And in addition to the companion volunteer program serving clients with dementia, we have our Vitals program, which is for people who live alone with a diagnosis. And this is a telephone support program where volunteers call to check in, but also to provide that socialization, really help combat the loneliness and provide a real kind of bridge between the client and Alzheimer's San Diego in terms of what their needs are. We hear a lot of needs that are identified from these phone calls that we're then able to provide support for. Okay, next slide, please.
Okay, so we'll address some of the questions that have come in through the Q&A. There she is. So the first question received was about what negative side effects could some of the FDA approved medications for Alzheimer's disease, what negative side effects could they cause in a person with FTD? Sharon, I'll take a quick stab at this, and then if you have anything to add, please do. My understanding, so some types of dementia, Lewy body dementia in particular, there are some actual contraindications. In FTD, I don't believe that there are sort of medical contraindications for the Alzheimer's disease drugs. It's just that they aren't effective. They don't work on this particular type of neurodegeneration. And so what they produce are the typical side effects, the GI side effects, nausea, diarrhea, dizziness, those types of problems. And then those problems in turn make the FTD symptoms exacerbate. They make those symptoms worse. Is there anything else, anything different, Sharon, that you're aware of?
We have had people that go on Aricept or Namenda and have sort of an opposite effect. Sometimes it makes their aggression or aggressiveness worse. So that is something that can happen.
Okay, sort of a paradoxical effect, maybe. Great. There was a question about whether or not having a DNR and a living will would suffice instead of a POLST if a person didn't have a POLST in place. I do believe that POLST or some version of it is available in every state in the US. I put out in the chat a resource for finding such a document in your area. But Sharon, can you speak to sort of the overlap or the difference between a DNR and a POLST?
Yes. The POLST is basically bottom line. They cannot do that. EMTs, if they come to your house, they are required to do life-sustaining. They're required to do CPR. It's a requirement for them. Even if you have a living will that says no resuscitation, they can say, take it to the hospital. Mm-hmm. So we've had that happen. That's why a POLST is a physician's order. Absolutely 100% must be adhered to.
Yes. I often explain that the DNR works in the particular setting where it was signed. POLST works everywhere. It follows you into any setting. So great. And one final question is, would palliative care be recommended for a person living with FTD who resides in memory care? Any
Yes.
differences there?
No difference, just like hospice.
Great.
So it's your management team.
Yes. Yes, it's a really great explanation of the depth of those services. Much appreciated. Okay, well, that was it for our questions. Thanks, everyone. We will wrap up here by just describing for you some of the resources that are available for more information about FTD and more resources for support. And again, as Sharon reminded you, and I put out in the chat as well, we will be emailing all of this to you, so you don't have to write any of this down furiously. I will also, in our follow-up email, I'll include links to the resources that were put out in the chat here today. So the Association for Frontotemporal Degeneration, the NIA, federal government, actually has a pretty robust set of information there about FTD on their website. Here is Sharon's podcast, Talking FTD, highly recommended. The UC San Francisco Weill Institute for Neurosciences has a lot of in-depth information, in particular, some great information about medication use in FTD available on that website. And here is Sharon's blog, Understanding Dementia Care Needs. So please do visit all of that for more information. For direct support, of course, Adriana described really nicely the array of direct support that's available through Alzheimer's San Diego, here through our various programs and supports. The For Their Thoughts Foundation is a nonprofit organization headquartered here in San Diego County, actually, but provides respite grants to people anywhere across the US who are support for caregivers who are supporting a person, a live-in care partner who is supporting somebody living with frontotemporal dementia. So I'm actually going to include some information about the For Their Thoughts Foundation in your handouts that will get emailed out as well. And here in San Diego County, we have a wandering response program called Take Me Home. We really want to encourage anybody who's been diagnosed or even suspects a diagnosis of any type of cognitive impairment, any type of dementia, to get registered in the Take Me Home. This is a voluntary registry operated by the Sheriff's Department. It's free, very easy to get enrolled. And then this is a system that works with law enforcement jurisdictions throughout San Diego County in the event that a person with dementia, a person with autism, any person who's at risk of getting lost, when they get lost, law enforcement can initiate a very prompt and effective search if the person has been enrolled in the Take Me Home program. There are a host of support groups available for people living with FTD. I won't go through the details here on the slide. I just wanted you to visually be able to see the array of what is out there, both locally as well as things that you can participate in from anywhere around the country. So here we are visually. This is Alzheimer's San Diego in a visual nutshell, if you will, our array of programs, support, and services, all provided at no cost. So please, there should never be a barrier to reaching out to get somebody some information or some support. Our services are all free because of this wonderful support of our local community, but we also are able to provide bilingual English and Spanish support services by phone or in person. And we also have access to a language line for providing telephonic support in basically any language. So please reach out, let us know how we can help you with referrals to local providers, palliative resources, or those companion cards that Adriana was talking about before. So that's the end of the program. We really appreciate everyone's attending today. You will be redirected to a quick survey at the end of this webinar when it closes. We'd love your feedback. It's anonymous, so please share freely any suggestions, additional topics you'd like to learn about. Very open to that. We always appreciate your feedback. You will be getting an email from us shortly here with all of this information that we've been talking about. And we really welcome you to contact Alzheimer's San Diego anytime with additional questions or needs that you or any of your clients or patients may have. So with that, I'll go ahead and wrap things up. I thank you again, Adriana and Sharon, for the terrific information, Sharon for sharing so much of your own personal experience and teaching others how to learn from your challenges. It's just invaluable. So thank you.
Well, we're all moving to San Diego, I'll let you know.
We will welcome you with open arms. Okay, well, everyone have a great day. Thanks again for coming, and we'll see you online.